So much. Let me bring my thanks so much, Corey. Thanks so much, Mike, the people that I know, and the state of Ohio, and everybody involved in helping problem gamblers. It's really good for me to be back in Ohio. Been there the last 3 years of physical when you had physical conferences, and I don't know if anybody, a lot of you who have been at the other conferences probably met me. I was at like the Gamban table or the TrueLink financial table. I did a presentation, I think they're about 3 years ago. And I don't know if anybody remembers, like 2 years ago when you had it, I fell out of the shower and ended up, a short trip to the hospital and then back at my booth. So I'm not going to feel the trauma of the Nationwide hotel bathroom right now. Thank you for putting me in this setting. So let me just, before I bring up the PowerPoint, I'll give you a little brief history of myself. And this will probably be the briefest of the longest of the four. I'm a recovering gambler myself. At the age of 5, the first time I spun a dreidel, if anybody knows what a dreidel is, I spun this dreidel and I beat my cousins for some pennies. I was literally off to the races. For me, I have genetic components in my family of most of them were all dead, but there were gamblers in my family. And, I took to cards right away. I was a terrible athlete. I grew up in a very dense neighborhood in Brooklyn where everybody played sports. I was the worst kid in sports, but you know what? I could beat them in poker. It made me feel, I'll never forget the first time I beat them all. I thought they were going to beat me up and take my money, but I got respect for the first time. I continued to gamble and had I was a pretty smart kid in math. I was running computers in the 70s, but screwed everything up because of my gambling. I finally got clean in 1979. I went to a Gamblers Anonymous meeting. That was the only kind of treatment that they had for gambling in those days, except for Ohio. Probably at Brecksville was probably the only formal treatment. But I went to a meeting, and that meeting transformed my life of knowing that I was not alone and knowing everybody there was like 20 to 30 years older than me, of knowing that my life was just going to get worse. Didn't stop me from, a relapse after 2 years. And I had moved to California, relapsed, took me about 1.5 years to get to my hands and knees. I continued to go to GA meetings even during my relapse. The people in GA were so supportive of me even during my relapse. This is not like a commercial for GA, but I think it's important to understand that GA is very, in my case at least, extremely non-judgmental. And finally got clean when I was 27, went back to school, became a certified gambling counselor, got very involved with the California Council on Problem Gambling. I was their director of training for many years. So I always appreciate guys like Corey and Mike, and how much fun it was. For me, I love training, but I got really involved. I got involved with California's treatment programs. So I've been involved in working with when I worked for UCLA, of being involved in every role. And that's what we're going to talk about today in terms of all the different treatment options and what it takes to go into treatment, of what happens when people go into treatment. We'll start with that one first, and then we'll finish up with case management this morning. In 2012, I got the Lifetime Achievement Award in California for working with problem gamblers and their families. So what do you do when you get the Lifetime Achievement Award in California? You move to Arizona, to try and start a new one. And I came out here, which was probably the greatest thing. I came out here to run one of the only inpatient gambling treatment programs in the United States, the only for-profit gambling only. And I got to run it for 5 years. I worked with probably about 800 clients, hardcore gambling clients, and managed staff. And I'm going to bring a lot of that knowledge into this. So just, I've had a very eclectic thing. I've worked with casinos. I've probably trained over 100,000 casino employees in 50 different casinos. I've been around, but now I'm very lucky. I'm getting to put it together. I'm working for a teletherapy startup where we're doing teletherapy for gamblers and gamers. And give my one plug, kindbridge.com. Check us out on our website, kindbridge.com. So, Corey said something, and this is why I do what I do, is 40 years of going to GA meetings, working with over 1,000 clients, hardcore, really direct, sponsoring people, whatever. When Corey said recovery is possible, I've been very fortunate in this world. I've probably seen more people recover than just about anybody in this business. I've heard so many stories. I've watched longitudinal studies of guys that I met in GA 40 years ago and women that I've met 40 years ago. And it is definitely possible. I've seen so many lives transformed. So let me bring up, that's me. All the next ones will be way shorter, but I like bringing I think it's important for me to bring my story in, because it's how, I'll never forget the very first time I did a training and I was all alone and somebody just shoved me in front of a group of 40 people. And I was so nervous. I just started, I said, "Hi, I'm Mark. I'm a compulsive gambler," because this way I share in GA, and things got easier. Okay, let me get my screen up. Okay. Get this up. Okay, everybody sees my screen? Okay, cool. Okay, case management treatment options. I don't know why I do treatment options first. So just to give you an idea, I'm going to go through all the different various treatment options, and I'm going to also talk about intake. I'm going to talk about then what happens with people who are in like IOPs or in residential treatment or what we call PHP, partial hospitalization. So treatment options. So I believe there are, there's probably one more, and I'll talk about that in a second, of different levels of care. And I'll go through each one of these things. You have outpatient, right? Where somebody just goes once a week, usually, could be a little bit more, where they're seeing a therapist. And we'll talk about what that entails. They're seeing a therapist, generally a licensed therapist, can be a counselor, a certified gambling counselor, but usually they do have a license now. It could be through teletherapy. Could be on the phone. The next level up would be intensive outpatient program, and that's for people who need a little bit more than just going once a week. Generally, intensive outpatient programs go 9 hours a week. It's usually 3 hours a day, 3 days a week, and it mixes group with individual therapy. Let me skip down to residential or partial hospitalization. Those are people who need a lot more, where they're living in a facility, whether or not, and I'll talk about the differences between residential and partial, and it's a 24/7 deal. And these are people, and we'll talk about what, might precipitate, going, instead of going to outpatient or IOP, to go to residential or PHP. Let's go to the left. I feel like I'm jumping around here. Post-residential or PHP treatment, whereas it's sort of a sober living environment, and we'll talk about that. There are hybrid programs. Most programs for gamblers are hybrids, where there are drug and alcohol or substance abuse, alcohol disorder place, doing treatment. And some actually have certified gambling counselors on staff, but you have to be really careful with hybrids. I'll talk about that. Whereas you're a drug and alcohol place, and you're answering the phones, and somebody says, "I have a gambling problem. Can you help me?" "Oh yeah, sure, we could help you." And I'll talk about what could happen in those situations. There's 12-step, is a level of care. Some people go concurrently with treatment, and some people just do 12-step alone. There are recovery life coaches, which is another avenue of having sort of a direct case manager. I have my certificate as a recovery coach, but I have a recovery coach. Well, you know what? I'll talk about it when I get to the recovery coach slide. I think I just got everyone, and just to, the asterisks there, generally IOPs, in most cases, IOPs are abstinence-based models. Residentials are definitely abstinence-based models, and Gamblers Anonymous or 12-step is, you wouldn't want to send a patient well, we'll get to that. Okay, so let's go with the easy one first, which is 12-step programs. 12-step programs can be Gamblers Anonymous, Gam-Anon, SMART or Rational Recovery. For many years, where, areas that do not, because prior to the pandemic, when there were no physical, where there were no physical locations in many areas, sometimes, and if there's a Christian-based 12-step program called Celebrate Recovery that offers help for gamblers, as well as any a substance and alcohol addiction, and to try and find them. There are plenty of support groups. One of the few good things about the pandemic is it opened up incredibly the access of people to 12-step meetings. It's, I've been going to meetings for 40 years. It's almost beyond my comprehension of the ease of anybody in the world getting to a meeting in 5 minutes, right? I'm sure you all know everybody know about gamblersinrecovery.com. Hopefully you all know about gamblersinrecovery.com. If it's not there, Corey, please put it in the chat. And yeah, if anybody has any questions, just pump them out to Corey, and Corey will throw in the questions when I take a breath in. Corey will try and get the questions in. But yeah, Gamblers in Recovery for both gamblers and family members can get on a 12-step meeting throughout the world, literally 24/7. Self-help support, it's an abstinence-based model. Like if you have a client who is doing a harm reduction model, you do not want to send them to GA and have them say, yeah, my therapist said, like I could still gamble a little. First of all, that person would probably be asked to leave the meeting. And then that therapist would not have, I think it's really important, in therapists working with GA to respect GA. They end up getting a lot of, on my experience, they end up getting a ton of clients. There's like a psychic GA network where, if they know somebody's good who's been helping other people, they'll do it. Generally, it's a 12-step based recovery plan with varying spiritual involvement. I'll talk a lot more about this at the end of the month when we go through the steps. GA tends to be, and Gam-Anon tend to be less spiritual. I mean, they're spiritual, they're less, they're more higher power oriented, and then SMART and Rational Recovery are not spiritually oriented. They're free. Case management, I sponsor a lot of people, so I'm a lot of people's case managers in GA. It is way different. And GA has incredibly good financial recovery components. I'll talk about that in the next workshop. Okay, outpatient. Outpatient would be an individual session, usually with a licensed therapist, or, which is really good. There's a lot of these, a lot of states have been really smart in creating licensed addiction counselors, where people, are above the counselor. Me, I'm going to be honest with you, I'm just an ICGC-II. So I don't really do much anymore. I do more case, when I was working in treatment. Now I tend to manage therapists. But I like the fact of knowing that I'm sending somebody to somebody who has a license, who is responsible, who has met the requirements by the state, who understands about the suicidal ideation, everything else, and knows what to do to protect themselves, protect their clients first, but also to protect themselves. we could see all the different letters up there. I'm probably missing other letters of people. I always believe the gambling certification training is way a plus. I'm sure many of you are either ICGC 1s or 2s or on your way to the training. The trainings are great. Most of them are being done online. Do you guys do it online in Ohio? Corey, a thumbs up, thumbs down? Do you have like the 30-hour training?
We offer stage 1, stage 2 trainings, which comprise 12 hours a piece. And then we have trainings like yours that are specialty topic trainings to kind of bolster up that 30 hours. We also have a GAM certification in Ohio that has the same requirements that the ICGC-I has, but it attaches either to their chemical dependency license or to as a scope of practice for counselors, social workers, and marriage family therapists.
That's very helpful. That's pretty much what I'm saying. I think it's really important to tie it to a license of some sort. Yeah, the amount of sessions may vary. Usually, though, it's once a week because these people are, in most cases, are licensed. They know how to treat for co-occurring disorders, and we always know they're the co-occurring disorders. Family involvement. I would say, to me, always the sweet spot of the people I've hired, and that's all I do on my other job is hire therapists, is MFTs are like my sweet spot because, although every other one of them works, but gambling is a family disease. And to be able to treat the family, to be able to do couples counseling sometimes in it, or know how to triage, find another therapist for the other family member. I mean, obviously, the client needs to have an optimal level of functioning. They need to be able to, and we'll see what, it'll be easier as we get through some of the other ones to see what is not optimal. And again, sometimes I really like this is the limited motivation to change. And that's sort of why they need a therapist. Based on my experience, I've worked with, like I say, probably as many gamblers, either through as a sponsor, through observance at GA or in treatment, who don't want to, even though they have to quit, they're coming into inpatient treatment. They're going to jail. They owe everybody money. They know that they have no more money. They know they have to stop. They don't want to stop. Why don't they want to stop? Because they got all that money out on the table. It's not like drugs and alcohol where there's that like little thought in the back of their head. If they get high, they're going to recoup all the money they spent on drugs for their whole life. But gamblers have that. And I think it's important to say is, the preparation stage for gamblers is like 15-minute window. When a gambler wants to get help, you got to get that help right away. You got to keep them, the first question I ask when I'm hiring a therapist is how well, and to explain what motivational interviewing means. Very important. And then usually cognitive, probably the two biggest things are that and cognitive behavioral, or CBT. A lot of times there's harm reduction models in this, because I think it's important in an outpatient is to meet the client where they're at. So, they don't want to quit. You don't want to give up on them. And, I've been to many workshops over the years and, generally down the line, even those people that decide a harm reduction model of saying, okay, what do you think harm reduction is? Oh, harm reduction. Okay. I'll gamble once a week, $300. I don't believe in contracts. I just, that's what they say. And they'll come in next week. So how'd that go? It didn't go so well, and I think it's a backdoor motivational technique of getting them to realize, what, they can't do it. And then, okay, I need help. It also can be, and a lot of times this outpatient could be post-treatment, helping with relapse prevention, of going over triggers that come up post-residential treatment. And sometimes, but not, I don't really think it's majorly their job for the therapist to act as a case manager. I think they should find a life coach, the therapist should triage out and find a recovery coach or somebody else to help with the case management. So let's go up one level. Okay, so and the cool thing about, just going back for a second is, therapy, when I said usually once a week, a lot of it has changed now in terms of I know so many more therapists will allow text messaging in between, which really is a very helpful thing. Okay, so intensive outpatient program can be either sober living. What do I mean by that? They're living in a group home, usually with a house manager or somebody who is, sort of the babysitter. There are rules in the house. We'll talk about that a little later, but they're going to treatment usually 3 days a week, 3 hours a day. There are 5-day IOPs, but generally the biggie is 9 hours. And the thing about that is okay, they've tried, I'm sort of going up the level. They tried GA didn't work, they tried going seeing a therapist didn't work. So let's go up a level, let's go, but they still need to keep their job. They need to keep their family. They need to come home or whatever, so, and more than likely it's not sober living. They're living, they're keeping their job, and they're showing up 3 hours a day, 3 to 5 days a week. Usually IOPs go 6 weeks to 3 months. It's usually run by and I'll talk more about different staff in a future slide. It's usually run by a clinical director, somebody with a license. And then there might be, in many places there are and we'll see this also in residential treatment, non-licensed counselors that work under the umbrella of the clinical director or behavioral health techs. So you could have, where I live in Prescott, when I moved out here, I said Prescott. That's the right way we say it. You always know somebody is when they say Prescott. You don't say Prescott in Prescott. When I moved out here, this was the capital of the world of treatment. There were more per capita people in treatment in Prescott than anywhere else, and because one of the reasons was it was very profitable. The insurance companies were reimbursing the agencies like $800 per UA. Everybody would make, and anybody with a license all of a sudden became a clinical director, hire a whole bunch of unlicensed people. And not to say that the treatment wasn't good, it's not a knock on that, but a lot of the facilities just had one person with a license. And then the rest sort of, they put it as BHTs, behavioral techs, and behavioral techs, some of them are fantastic and do a great job, especially based on supervision and staffing. Usually they'll get a weekly individual session with a therapist or a counselor. So usually they're only going to get one. It might be two, one with a case manager and a therapist. It's mostly group sessions. So, 8 hours of it are process groups. I'll talk a little about that a little later. Psychoeducation, relapse prevention. And a lot of IOPs will have a peer counselor on, and they'll do, one of the hours might be a peer group with a peer counselor. Family involvement, some will actually have, which I don't know if anybody here has ever done family group for gamblers, with gamblers and their families. Nothing, to me, that's the apex of doing treatment in what we do. Every session I've ever done with family, and it's way different than drug and alcohol. I've been involved in a lot of family weekends when I worked out in the treatment, but when we see family, so I've been in a lot with substance abuse clients and with gamblers, and the anger with the two things that are so unique about family work with gamblers is the anger is way more, but the fact that they think they could fix it is way more, and the dynamics are incredible. Case management, again, very important. You have clients who have financial issues, legal issues, and we'll talk about that later on in the training. They might have housing issues and whatnot. So we'll get more into case management later. I put 3 explanations. I hate doing notes. That's why I'm really glad I ain't doing notes anymore. Notes are really important. So every client, these are, which I probably should have a thing. They're generally either insurance-based or state-based, either state funded or you're paying, or your insurance is paying it, or it's cash pay. But you need them notes. You need the initial intake of biopsychosocial. I don't remember if I have it in another slide, so I could just say it now. Generally, the minimum is, an intake, a biopsychosocial, a master treatment plan updates, progress notes for each session, and eventually a discharge note. And it's a skill of doing notes. I actually got pretty good at it. I've learned less is better, and there's so many different. It's all like most of them are are EMRs. When I first started, I had to write up. I had this, like, at the end of a group, I'd have like 20 folders, and I'd have to write in each folder. It's much easier now, and based on your company, on what there's probably 50 different companies that sell systems for notes. Some are better than others. And we'll find a lot, generally in intensive outpatient program, there's concurrent 12-step, so they are going to meetings. And sometimes one of those hours, there's an excellent IOP in San Diego, they consider one of those 9 hours of going to a GA meeting or going to a Gam-Anon meeting. So this is the thing that I know better than anything else, because I worked in what's known as a PHP, partial hospitalization program. A lot of people will just call them inpatient or residential, but they're not true residentials. But this is a really common also for substance and alcohol disorder of PHPs. Okay, so now you have somebody coming in, now they need an even higher level of care. And it might be, in gambling, and this is anecdotal, I'm going to guess about there's maybe 25 to 35% of co-occurring alcohol and substance. And there's probably somewhere between around maybe 5% of people where it's that bad that they need to go to detox before they'll go into either PHP or residential. And so generally we'll send the client to make sure that there's substance abuse or alcohol is, because otherwise they're not going to be a good patient. These are people now, they're going to be living with other people, and for sure. And it's a very interesting dynamic, and we're not talking about, again, I worked a lot in substance abuse. Substance abuse, it's usually young people, that, usually the average age in substance abuse is like 19 to 25. And for them, it's like going to camp, Gamblers are more adults. They generally have a career. They've got a family, and they've been able to take really good care of themselves. And now they're sharing a room with 1 or 2 people in a different environment. One of my favorite things was I actually got them to put full-size beds in our house. A lot of times, they're sleeping on a twin bed, if they're lucky, and have to adjust. So what makes PHP different from residential, the housing is offsite of the treatment facility. And so you're not, in most cases, it's illegal to do treatment at these houses. So they're living in a house with a house manager. They eat their meals together. They live together. They are picked up in the morning. They are generally, vanned in to the actual treatment center where the treatment is done, to the treatment offices. They're vanned to GA meetings at night or other 12-step meetings. Some places come home for lunch. And they're eating their meals. And there are house meetings to make sure, because there's always some kind of problem going on. Again, you're living with a whole bunch of people. All of you have, I'm sure this ain't your first rodeo, and know that, there's a lot of at least narcissistic type gamblers, and they're all living together. They all know what to do. They, in the places I worked for, they did their own cooking. We would take the clients to a supermarket on Fridays, give them a card, a Kroger card. You have Kroger there, I'm pretty sure. We call it Fries. They get their Fries card. We'd have one house manager guarding the alcohol line. I don't know if they sell alcohol in your supermarkets, but they do here. And, they would cook, and everybody wanted to be the cook. So houses could be either same sex, or some houses have, and this is the interesting thing about gambling. In drug and alcohol, I would never even think about having a mixed house. In gambling, there are less problems, but that's not to say that those problems do not occur. Generally, the house managers are regular employees, and in certain states and certain jurisdictions, the house managers need to be either certified or licensed or have taken a certification training to know things like CPR and other things, and know how to deal with aggressive situations. Usually, again, like I said, it's run by a clinical director. And then sort of like the IOP, there could be non-licensed counselors and licensed counselors too, that work under the umbrella of the clinical director. And those would be behavioral health techs. They usually do group. They're usually in group most of the time, 5 to 6 hours a day. They're usually, the stay in these programs are 30 to 90 days. For me, the sweet spot is about 6 weeks, because now you have to realize these people, generally have to go back to work or something, and they get really antsy. And gamblers, here's the interesting thing about gamblers in treatment. And again, and I hope I'm not getting this wrong, but this is again based on my experience. I've worked with a lot of substance abuse clients early on in my career. Any good gambling counselor generally had to start off working with, getting your, like Corey said in the beginning, getting a drug and alcohol certification first. So I did my work there. I'll never forget the first day I did group. I was like right out of school. I'm doing my first group. Everybody is like nodding, like I'm the greatest group leader in the history of group leaders. And everybody going, yeah. And they didn't remember a thing I said, the next time, they had no idea what I was saying, but they nodded. They know how to nod. You do a group with gamblers, they will remember everything you say and use it against you. And that's why sometimes I think, unless you could really engage them after 6 weeks with new material, they get bored really easy. And again, is that evidence-based? No, it's my, it's just based on a lot of really good observation. They generally now in this partial hospitalization, they're seeing a physician once a week. They usually have, the reason why they're an inpatient, they usually have acute symptoms, and probably one of the hardest is there's still suicidal ideation. A lot of times, when it was my decision, I would not take clients in heavy situations like that. but some people would. And make sure, there are other acute symptoms like diabetes, can we manage that? So when we go to residential, and the next thing we'll understand that, then you have more full-time nursing and whatnot. So the level of care of how they can function, because again, here's the interesting thing about PHP is they have to travel together as a group, right? So they have their weekends, and generally there is no treatment on weekends. Maybe they do a deep clean on Saturday, or they'll do an outside activity. So you have to keep everybody together. And during the weekends, activities might include taking a hike or going visiting. We're very lucky in Arizona. We, especially where we are, we'll take our clients to Sedona. Well, if anybody's been to Sedona, it's usually an incredible experience for the clients to be in Sedona, because it's way bigger than them. Or occasionally we'll even take them to the Grand Canyon. So we want to make sure that everybody is functioning both physically and at least are, mentally stable. There are always co-occurring medical issues. And again, if it's a situation, it gets really tricky of diabetics who are taking insulin, to make sure that there are refrigerators in a room, all kinds of stuff like that. So sometimes PHP will not take certain clients based on that. Weekly individual sessions with therapists and counselors. To me, the ideal thing would be, and we were able to do it, is to have their regular primary therapist, generally a case manager. We were very lucky in our place. We had a trauma therapist to start working with the trauma issues, a peer counselor. I've been in other places that, I don't know if I have it in a slide, that had a spiritual counselor, which I think is really important. Just looking back at my own, but that's a personal thing for me. It's mostly group sessions, and I'll talk about what groups look like in a few minutes. And the groups could be like process groups, psychoeducation, relapse prevention, process groups, I'll talk about that in a few minutes. Peer, the whole, they're addressing denial, triggers, relapse, potentials, risks, financial recovery. And here's the interesting thing about gamblers. I can't tell you how many gambling groups, I've probably done as many gambling groups as anybody, is process groups are really interesting. If you ask a gambler, well, tell me how that makes you feel, the first 5 answers are usually not a feeling. There's something else. And what we find, though, is, in a group setting, when one of them locks on to a feeling, then everything opens up. I'm a real big fan of group therapy. I'm a real big fan of group therapy. Again, I've hired a lot of therapists, and the therapists that I've hired, 99% of them are not recovering, which I like about, maybe I'll talk about it. I like the fact that most people that treat gamblers are not in recovery from gambling, because well, that's another story. But I think non-gamblers ask better questions, are much more open and better listeners. But the group leaders really get to learn a lot about gamblers in group. Family involvement. I was very lucky at the facility I went to. We did family weekend every other week. That we did combined with the substance abuse clients, which was also very interesting, where we had the family, the family would come. We'd do 2 full days of family workshops. We had the person who I worked with when I did family was this woman, Dale Ryder, who was a genius in doing sculpting. And we do these incredible sculpts, family sculpts. If anybody knows what family sculpting is, look at it. It is unbelievable. I couldn't work on Mondays because I just cried all weekend. It was just great stuff. They do alternate activities in there, like they might have a yoga class. Again, we were very lucky when I worked, we had equine therapy. And equine therapy is working with horses, which usually the very first day our horse players get really excited that they're going to work with horses, but you don't ride the horses. You're not betting on the horses. It's a, and we're doing with people who are certified in doing equine therapy. It is amazing of the breakthroughs that our clients have had, especially the you know, later onset women who their very first session had, you know, it brought back so many, you know, they had this fear of horses, brought up a lot of trauma issues, and they were able to work through it with the horses. Ecotherapy, I'm really big in ecotherapy. That's because I'm too lazy to do group. You know, I'll just take them out on a hike or something, and or go somewhere and get their observations. You know, and many other things. You know, there are places that do neurofeedback, which is great. There's a place in Los Angeles that has like surf therapy or art therapy or all other kinds of cool stuff. There's always case management, you know, where you're working with a client from beginning to end. And I'll talk about that later. I would say just pretty much every one of them has concurrent 12-step where they're taking the clients to meetings. Usually the meetings are at another location, you know, it's getting in the van, you know, that van is a big thing in PHP because they're going somewhere all the time, whether back and forth to treatment. Again, notes. Okay, so now they need more. You know, I think that covered pretty much PHP, and now they need a little bit more. So we'll talk a little about residential treatment and what that looks like. Again, you know, pretty much for the same reason, and it might be even more often in the residential unit. Here's where everything is on site, right? The only thing that might not be on site is them going to a 12-step meeting. That's pretty much it. Or maybe going on an outing, you know, but very structured. So certainly there you have your detox. More than likely, you're going to have a higher percentage of detox. Not that it's that high for gamblers. Again, on-site treatment, clinical director. Same thing as I said before, you know, there are non-licensed counselors or licensed counselors. You know, I always made sure, and now it's really good. You know, now it's so easy with states training, like what Corey said. You know, there are plenty of people who at least have their ICGC, and those would be the ideal people to do. You know, here's a great opportunity for them. It's a great opportunity. Like if you don't have your license yet, you know, and you could intern in some place that's working with gamblers, that's just fantastic. You get your hours in and you work towards your license. They're usually going to group 8 hours a day. Everything is super structured of what they're doing. And I'll talk about groups again in a few minutes. Those usually go, you know, like the old days, 28 days, you know, that was the number for substance abuse. It's usually, again, between 30 and 90 days. And again, you know, drug and alcohol, I think, should be a lot longer, you know, and maybe in residential, usually I would probably recommend the 90 days because then the family understands way more. Here's a dynamic, you know, that again is based on observation, is a lot of times, you know, when, you know, why the treatment isn't as long is, you know, this is the one part about residential and PHP that offers some challenges is, you know, just imagine this, you know, you have a gambler coming in to treatment. Now, this gambler, if they're in either residential or PHP, they have significant problems. I don't think I've ever, you know, in doing the DSM when I'm doing, I don't think maybe once or twice, maybe once a 7 out of 9, you know, they're all 8s and 9s, you know, and they've all created tremendous problems and generally tremendous problems with their family. So just imagine like this, they come in, here's the challenge. They come into treatment, the family is at home and the family's now got to figure out how to pay the bill, because usually the gambler was the bill payer. They got to figure out how to pay the bills, especially, I can't even imagine during the pandemic, take care of the kids, do everything, you know, and they're worried. And every day some new, because now they're answering the mail, a letter's coming in saying how much money they owe, or phone calls coming in saying, you know, your husband, your wife better pay me the money, right? And then, you know, it usually in residential and in PHP, I don't think I have it as a bullet point. You get to call your family once a week or twice a week or however the organization wants. And you call your spouse up or or another family member up, and they're in panic. And you say to them, oh yeah, I went to equine therapy today, sometimes creates a challenge. So again, I think it's really important to work with both. So they're usually gone 30 to 90 days. They have to see a physician. And I'm not sure why I don't have the bullet point in both cases of residential and PHP, they have to see a psychiatrist generally within the first week. Some states it's 48 hours, and those things vary by state. But they need to see a doctor right away, and they need to see a psychiatrist generally within 7 days. Some even more, with a shorter window. The psychiatrist part is really important. They have 24/7 nursing. So here's the difference. So in residential, you might be able, now you could take a diabetic with insulin and other medical issues. Generally you're going to have really post-acute withdrawal symptoms, certainly co-occurring medical and other issues. That's why they're in, residential is a hospital in a way, a hospital setting. I don't think I've ever not seen some kind of co-occurring mood disorder of somebody in residential treatment. And I would say at least 75-80% in PHP. Again, and I'll talk about what these stresses are and whatnot in another slide. Complex psychosocial, again, the family involvement is really involved. And the goal is to get them out of residential treatment, is to titrate down, maybe get them into a PHP or an IOP or into sober living. They're addressing the denial, and there's heavy, if you're in there, there's heavy denial. Like, again, even though these clients know they have to be in there, they don't want to be in there. They still think there's that solution, and that they owe people money. And that's why we'll talk about money in the next thing. And they're afraid, again, we make sure that, again, the medical, that's why it's residential, the medical and medication stabilization, and quite often, medications have to be changed. I went through this a lot. We were very lucky. I had a really good psychiatrist who really wanted to learn about everything. And, there are certain medications that are agonists for gambling, right? So what do? Do you take them off the Mirapex? We have a lot of patients coming with an Adderall or a Abilify, and what do we do? And I think they're still working out what to do, and again, this is anecdotal. I found that sometimes taking people off, completely off some of the drugs that they've been taking, like Mirapex. Mirapex is a Parkinson's disease drug that can be an agonist, a dopamine agonist that can increase the possibility of gambling and other addictive behaviors. And do we take them off? So there's a lot of things, I found that, generally when you take them off, then they're no good in treatment or group. And a way of titrating that, that's way beyond my grade, but I think it's really important to have have a psychiatrist who understands medication. I know there's you just happen to be the only person. Bill, did you have a question?
Yeah, well, I had a comment. There's actually, we run a residential program at the agency I work for that is a non-medical community residential program. So there is no doctor on staff. They have access to doctors, but there's no psychiatrist. And I disagree that they have to see a psychiatrist. It doesn't make sense to see a psychiatrist unless they already have a co-occurring diagnosis, because often, since most residential or most people that are going into residential have a co-occurring disorder with substance abuse, need to clean out before they are diagnosed with any mental health disorder. And often they get diagnosed with the wrong diagnosis early in recovery.
Well, and again, it might be a state thing, and it's not that they have to see on a regular basis. They need
It's
to
not
get,
a state thing, it's an ASAM thing. ASAM does that.
okay. So thank you. Thanks for your comment. Okay, and again, certainly notes and notes. So what are some of the goals in inpatient treatment? The first is, again, it's an abstinence-based model, help the patient stop gambling. Again, here you have a safe environment for assessment and treatment, and it's very important. As me in my job as program director, that to me was my primary, it's my responsibility to make sure that the clients are safe and that they feel comfortable, and especially in an inpatient situation when they're living with other people, is to be on top of that. Then to provide a comprehensive biosocial to do a biopsychosocial, to find out the most efficacious treatment recommendations. And we'll talk about that. I'll talk about the intake in another slide. Individualized comprehensive treatment planning and intervention and continuing care recommendations. I'll go over that at the end, about continuing care recommendations. To establish trust in the therapeutic process, right? It's really important. I'm sure you've heard it all the time, the importance of the therapeutic relationship, enhancing motivation, decreasing ambivalence, and work with the clients. I mean, when you do a master treatment plan with the client's signing off on the master treatment plan. It's not you're just saying, okay, this is what you have to do, or there's a cookie cutter plan. You have to individualize it again based on the assessment and the intake. Again, to help, here you're in a better position to establish trust, to help the patient cope with the impulse to gamble. Again, it's easier there. There are a lot of places that do things like, probably one of the biggest problems that I ever had was keeping the phone away from our clients. They wanted their cell phone. I even had one client say he's going to kill himself just so he can get his phone. I had to take him over to the local hospital, and he was smart. He got his phone. But there are certain places that sort of desensitize towards the end of their treatment, maybe give them their phone limited the last week, or things like that, for them to understand the nature of the disease, the etiology, how did it start, the progression. And I think it's really important to educate the clients on what problem gambling is, the same gambling 101 that you probably got, or an advanced thing, that they should know as much as you do about the disease of gambling. Again, to provide education on relapse, phenomenon, risk factors, triggers, and we'll see how that all plays through, I think, as we get on. The maximized level of functioning with coping skills, rational thinking. That's one of my favorite groups. I do irrational thoughts, where I have the clients talk about irrational thoughts. It's quite interesting. My favorite one is, if I gamble long enough, I have to win back all my money. Interpersonal relationship skills, especially also, there's some really great stuff that, and I'll show you a page of it in a minute, done by Nancy, that was done by Nancy Petrie on assertiveness training, things like that. Stress, to me, stress is really important. Things like yoga, things like taking them to Sedona, teaching them doing meditation in group, or finding other ways to reduce the stress. And we all know that, especially when gamblers come into treatment, they stop doing the things that they used to like to do. Their wants, their needs, their dreams, their hobbies, do not pay off in dopamine the way gambling is paying off in dopamine. And to sort of get them back and to figure out, again, maybe go back to school, maybe figure out, start going fishing again, or cooking, or vocational. They might work at a racetrack, or be around, or work in a casino and be around that, or work in the stock market or whatever, and maybe to think about, changing vocation. Honesty, that goes without saying, to be able to live in reality, and again, I think, especially in inpatient, you have a better opportunity to work on that, to recognize unhealthy behaviors. One of my favorite groups sometimes is healthy behaviors other than gambling. And the first time I go around the room, they're all unhealthy behaviors that they think are alternatives to gambling. Identify spiritual support. I'm a big fan in that. I'm really a big fan in the spiritual part, not religious, but spiritual part. And sometimes that part is very difficult because it's hard for gamblers to sort of separate that and to understand the difference between GA and treatment. Goals, decrease shame, isolation. Shame is really big, or guilt. The omnipotence and ego-based thinking, which is really fun. And a lot of it'll go down. Again, the group setting tends to really help with that. We'll talk about, in a little further on. I won't go through these bullet points on the continuing care. We'll talk about that a little later. And to, assess how's treatment going, right? How's this going, right? Do we need to make adjustments? And I think follow-up, we'll talk about follow-up. This stuff came from Trimidian. Trimidian was going to be like, Trimidian was, I believe, was in Indianapolis with why can't I think of her name all of a sudden? Joanna Franklin, Dr. Rosenthal, Laurie Rugel, a whole bunch of other cool people were trying to put together something about 15, 20 years ago, but they did some incredible work. So let's talk now about post-treatment, maybe post either residential or PHP treatment, would be sort of sober living. And sober living is about sort of the maintenance of it. So generally they're living in a sober living house, which might be similar to like a PHP, but here they have the ability to come and go. They have the ability to work, but they also have to, generally there is somebody in the house that, not as strict as a house manager, or sometimes they'll use them for activities or driving them to certain places. Generally in this house, they are attending meetings. There are a requirement that's usually that they have to go to X amount of 12-step meetings a week. They might have to be seeing at least doing one outpatient session a week. They might have to go to group therapy. They might have a life coach. They could be involved in alumni groups, and in certain cases that they're taking care of medication management. So this is, like sort of the equivalent of sober living that you would think for drug and alcohol. Then, and this is always interesting, is the hybrid treatment options. They're usually substance or alcohol treatment facilities. Same attributes as residential treatment and PHPs. And, and sometimes they're good. And sometimes, I think they sell the gamblers short. A lot of them are very good. They have certified gambling counselors, people who are trained in gambling. And those tend to be can work really well. At least they have somebody, they might be going into groups. They might have, most of the groups, they're going with the substance and alcohol clients, but there might be one or two groups at least a week that are gambling specific. Like I said, hopefully with a certified gambling counselor. And, I can't tell you how many times that people have come into places that I've worked for where they called up a place, they went online, they called up a place, the place even had gambling in their they bought the keyword on Google or whatever, and people look up gambling treatment and they call a place, and the place says, sure, we take gamblers, and there's no certified gambling counselor. They're just getting, and they're the only one, the only gambler. They're all with substance abuse clients or substance or alcohol clients. So hopefully, usually the housing is shared, so they're living in the same house. But here's the part generally that I found in most cases of hybrid treatment. Again, you have to think about it. They go as a group. Like, you can't leave somebody home, right? You only have one van. And usually the gamblers are going to AA or NA meetings. They don't have access to GA meetings. Maybe if they're good and smart, and if somebody pushes hard enough, they'll get to go to one or two GA meetings. And sometimes you might have to get somebody from GA who you trust to come pick the client up, take the client to the meeting, and bring the client back. So they can work really well, but I would be really careful of sending somebody to a hybrid program, and make sure that they know what they're talking about in terms of gambling. Recovery life coaches, they're usually non-licensed. They're certified. I've gone through the certification process. There's a strong, there's a very, very good trainings for some of them, and some of them maybe not. That's up. You have to investigate what agency that you're taking your training with. There is a large scope of practice. This is why I'm a terrible recovery coach. I've been too much a sponsor and too much a counselor for me to find that middle ground. But they're meeting the clients where they're at. They're managing the clients' day-to-day activities, which could be 12-step attendance, appointments, like appointments like making sure they're going to the doctor, showing up at job interviews, mental health, or whatever they need. And they also help coordinate legal financial issues. Right now, a lot of places are hiring recovery coaches. Recovery coaches, and again, the training I took, at least it had a section on gambling, and I found it very helpful. So that would be another way of working with somebody long-term. So, how do we treat the appropriate level of care? Inpatient treatment may be needed any of the following. Why would we send somebody into inpatient treatment? Heavy depression, suicidal ideation. They have a plan, they have attention. There is the chemical dependency, risk of withdrawal complications, severe psychiatric illness, impulsivity. They just can't stop. And I've seen a lot of those clients, they cannot stop. And they're trying to gamble while they're in treatment. They've tried everything else, or they have little or no external support system. So again, other things is they're tired. Gamblers tend to be less than substance abuse clients, but I've certainly seen, especially the emotionally exhausted, they don't come in to inpatient treatment or PHP, residential or PHP, until they've exhausted all their resources generally, and they are exhausted, or they are tired, or they're contemplating crime or other serious dangerous behavior, right? I'm still a big fan, I'm old school, still a big fan of Dr. Custer's progression, of where they're moving down that list. They're usually at the hopeless, they're certainly at the desperation or the hopeless phase, and contemplating some tough stuff. Maybe, again, other areas of impaired function, unstable, crisis. And I don't know, again, I'm giving credit to where I got this from. I'd be careful of bringing in clients with homicidal ideation. Another, how much you're gonna, these are treatment decisions, and this could be for individual therapy of how frequent are the sessions, is there phone tech, what style, should should the therapist take? Again, are we worried about, is the gambler living in an unhealthy environment? Are they in danger? Can the family be involved in treatment? And I think it's really important when looking, a lot of, because those $800 UAs are out, a lot of places cut down on family weekend and things like that. And, I think it's really important to find out how the family can be involved in treatment. Do you see the spouse and the gambler? Should you have somebody else treat the other person or do it in a group setting? Initial treatment, medication needed. Are they living with somebody who's an active gambler, drug abuser, alcohol? Or is the person being abused and that's why they're doing it? And this stuff comes from, my mentor. And actually, I couldn't have been luckier that when I first, and that's why I'm such an advocate for me personally for treatment and 12-step. But, this was adapted from Dr. Richard Rosenthal, who I'm sure many of you have seen at a conference. And he was my psychiatrist for the first 3 years when I first got clean. And, Beverly Hills on the couch, psychoanalysis, and saved my life. So this was put together from Dr. Rosenthal. What kind of objectives are there? Again, let's talk. I'm not going to go heavy into this about the intake evaluation. This is stuff that you guys do anyway, in any kind. This is more generic. I'll talk about the gambling specific in a second. We want to find out, past psychiatric illnesses. Do they go to treatment? Were they diagnosed? What medications they're taking? Physical illness. Again, I think it's really important. Again, we're the place I work, we're big in maybe than I was in terms of making sure that they've had a physical checkup, family history of psychiatric and physical illness, history of prior treatment. In gambling, sometimes you'll usually find it's their first when working with drug, but we'll find out other things about that. Their co-occurring drug and alcohol use, relationship history, legal history, and their social support, their job, their education, their family dynamics, especially the quality of relationships, the suicidal assessment, ideation plans and attempts, their mood, their general functioning, find out where they're at mentally, find out where they're at religiously or spiritually, current and past. Sometimes that can be used. Now we're talking about, and adding to this, this was put together by Dr. Eric Geffner, another one of my mentors early on. And, things like understanding gender now, I think is really important, and how people self-identify via gender. So in terms of gambling specific intake, and again, this is stuff you've probably gotten somewhere else. I'm going to go through this one fairly quickly, but maybe a little bit more detail than the generic one is. First of all, a lot of times they'll be seeing you because there is a legal situation. We have it quite often, and people will go into inpatient treatment to help mitigate, possibly, because I've already said this is a smart thing to do. Go to treatment. Maybe it'll get you reduced. Maybe it'll help mitigate your sentence. But quite often there is a legal situation, especially in residential and inpatient. I mean, when I say significant, it's maybe, again, I'm being anecdotal here, somewhere between 10 to 25%. We want to find out what games they played, why, I think it's usually important to know whether, they're action oriented or escape oriented. Details of the gambling behavior. Again, we could use that to help work in relapse prevention and determining triggers and how to address them. Their cognitions, my favorite, among sports bettors is magical thinking, right? They always think they could pick that winner, and it's going to win because they bet on it, because they know something. They, somebody gets in front of them when they're watching the game on TV, and all of a sudden things go bad, or find out how much they're thinking about gambling. I think probably one of the most important things is to identify the dream world of the gambler, and I can't tell you how many times by the time they get to inpatient, there's no more dream world, they forgot those dreams, or they're pretty simple. I'm just doing it to escape. I don't need the money. I just want to gamble. They're motivational gambling for gambling, and it could be neurological. Their reactions to gambling, guilt or shame, whether that not they feel depressed, which usually depression is then the trigger for them to go back. Again, their personality factors, whether or not they're action oriented or escape oriented, degree from others to quit. One of my very first, when I first was learning in drug and when I was going to school to become a drug and alcohol counselor, my teacher said, you have a problem if somebody else says you have a problem. Reasons for quitting now, that's always my first question, always, is why are you here now? Past attempts at GA or quitting, longest period of time without gambling. What do we use that for? Is to, find out one of their strengths. What'd you do? What was going on? A degree of impulsivity. And some people they're gamblers. That's their life, right? That's their love, of, I don't want to give it up, okay. Access to cash, again, for triggers, degree of dishonesty. How bad is it? Especially in terms of the minimizing of the gambling behavior, where they're at in state of change. Did I left out prep? Well, that would, I guess Dr. Geffner left out preparation in that one. Other treatment considerations are, staff, what we might find at various things are like, usually it's run by an executive director, clinical director, the responsibility generally in the program director, make sure everything is working, not necessarily licensed. Again, many places do have either a psychiatrist or access to a psychiatrist. A couple of places I worked in, a psychiatrist would come in one day a week and work with the clients. The psychiatrist was not there all the time. Some places have nurse, licensed therapists, counselors can be either licensed, certified, or what I said before, BHTs or peer counselors. Housing, generally you have an operations manager of housing, house managers, somebody doing the maintenance, and sometimes some facilities will have drivers, specialized staff. Again, a lot of these things they broke up, but like an equine therapist, arts and crafts, yoga, dietitian sometimes is really important. You have people making sure that their insurance is covered. You have a lot of people with things like FMLA and other things when they're coming in to make sure that they're able to keep their job and filling out all the correct paperwork. Sometimes they'll have a financial specialist. Somebody will help them navigate their finances, because that generally is the biggest stressor. When somebody's calling up to find out a treatment, if you're calling up a treatment and you want to find an inpatient treatment or PHP, residential, you want to find out, here's some questions you might want to ask. Is it gambling specific? Is it a track? Is it a hybrid? How long is the program? What's the housing like? What kind of staff do you have? Gambling specific people. If you're a family member, and a lot of times we get the calls are going to come from the family, can they be involved? What's the schedule? How are they eating? What amenities? And I put this down here, which sometimes, you have to let the gamblers know, it's just the nature of the way treatment is. They're not getting the $800, so it's not like they're getting money out of it. But, I can't tell you how many times gamblers have complained of why they have to do UAs. They don't have an alcohol or drug problem, and they're not serving. There is also abstinence in alcohol, even at pure gambling programs. Assignments that might happen, in treatment are things like family of origin, consequence assignment. I'll show you the consequence really quickly. A timeline is probably the biggie. Anybody ever see, you know, you can put it in the chat, probably one of the coolest things to really understand about it is betting on Mary. Has anybody ever seen Betting on Mary? You know, if you have, yeah, it was one of those NBC shows, you know, where they do an hour show on something, I don't know, Dateline, you know, where they take a person through, it's really done well. They take a person through CORE in Louisiana, and they really get into it. They allowed it all to be filmed at CORE, really cool thing. And they do the timeline in there. You know, get a sponsor. Some places work the first 3 steps, or the GA20 questions, a farewell letter to gambling. I mean, these are just a whole bunch of stuff. I'm just throwing out every one that I've ever heard of. Something on financial recovery, recovery goals, triggers, relapse plan, continuing care. I'll talk about that in a minute. Like a consequence assignment might look something like this. I don't know if you guys could see it, you know, where they have to check off and write little things about consequences that they've experienced, both whether emotional, physical, spiritual, career, other consequences. And this sort of goes in line, this one with, it's sort of the first 3 steps of GA, but especially focusing on the powerless step of step 1 and unmanageability of behaviors, of them listing down things that they were powerless over, and then things that their unmanageability inventory. You know, it's a pretty cool thing. And again, it really helps them to realize, you know what, this is really who I am. This are the consequences. And, you know, if I look at it from a step perspective, the first step, and I'll talk about that at the end of the month, is I am powerless and my life is unmanageable. Not only can I not stop, it's also ruining my life. And this assignment helps them work on both. You know, a timeline, I really don't want to get into this. I'll send anybody copies of this. I don't think I didn't send Corey copies. I just added this in. Doing a timeline, which usually is very helpful. You know, it covers a lot of bases. A schedule might look something like this. You know, where they're going to group, they have meditation in the morning. The groups vary from primary groups. I'll talk about that in a second. You know, they might go to a GA meeting at night. At night, they have some free time. Their meds are managed, so maybe they have some people have to take meds in the morning, lunch, and at night. Maybe they have some free time in the afternoon to go to the gym. So this is just a typical thing. Generally, there are different kinds of events on the weekends. Groups, you know, generally they're primary process groups where anything can go. This isn't a class on groups, but some primary groups might be where they bring their consequence into a group, their assignment, and then other people comment on it. They might do their timeline. A goodbye group, I'll talk about that in a minute. Then there's which I love doing, psychoeducational groups, understanding gambling disorder, financial recovery, what's GA about, family systems, working the 12 steps, trauma. I'm a big fan in Pleasure Unwoven. Don't ask me why. I love that video. I'm sure some of you have seen it, which goes through the brain disease model. I think that I've always found really helpful to get them to understand the brain disease model, and it lets them try and figure out a little of realizing that to cut down stress and to increase their coping mechanism are in their best interest. You know, experience groups. Gamblers are incredibly good in psychodrama, team building, field trips. You know, they sort of get that DBT experience, spirituality. Relapse prevention is great. Nancy Petrie put together, I'll show you a page of one of the ones she did, and other things like equine movies, you know, we show the clients movies. And, you know, it's always tough. Are you going to show them a gambling movie? You know, there's some places that show like Owning Mahoney, if anybody ever saw Owning Mahoney. I think it has some good points. You have to really worry about triggers in any kind of movies, yoga, nutrition, art. I talked about this. You know, this is an example of one of Nancy Petrie's thing, and really good stuff. There are 8 exercises where they go through it, and really things like assertiveness training, alternate activities, dealing with triggers, really cool stuff. You know, I'm not going to go through these. You could just look at it really quick. If any of you, you know, are treatment providers now or studying to be treatments, you know, there's a whole bunch of different kinds of groups. How do we access gambling treatment? You know, it could be done through web searches, you know, searching for problem gamblers. You know, usually problem gambling therapists, usually you'll find a link from Psychology Today. You know, searching will bring up treatment programs. NCPG helpline, 1-800-522-4700. I think I have a slide on Ohio, so don't worry. National Council MPs. Like you go to ncpgambling.org, it'll list the certified counselors in treatment facilities, state-funded treatment. You know, many states have free, which is really amazing. You know, the difference now. It sometimes drives me crazy in GA when people keep coming and say, my therapist said this, and it's just so unique for me now, but I think it's a great thing. Like I said before, for me, I think, you know, for me, the combination of 12-step and treatment is very powerful. Free state funded. You can search for state problem gambling councils. Ohio, you know, I found all these different, I'm not sure which is which, but you have gambling help, ohio.org, pga@ohio.org/resources, casinocontrol.ohio.org. I believe this is your helpline number, right? 800-589-9966. Okay. And now, and also, you know, plug for my company. I won't mention the name, I mentioned it earlier. There's a lot of now teletherapy options for people with gambling problems. You know, here, you know, I just took a screenshot of the Ohio Casino Control Commission, where it lists information on the left of 12-step meetings, and then on the right of phone numbers for recovery. You know, discharge and follow-up, you know, in discharge, they complete the program. Some people leave early. We would say it's against staff advice, or we determine whether or not the person is ready. Also, we try and suggest the length of stay, that they finish their assignments, and that there is a discharge, that we give them a discharge summary with recommendations. So that's what I'm going to do for the rest of the class in talking about case management. And most places, everyone I know is the goodbye group. When somebody leaves, they usually have a really fun group where everybody says goodbye to the client. You know, this is just a personal observation. When I did groups with Gamblers Anonymous, and you know, they're doing the goodbye, I mean, with substance and alcohol clients, when they said, "Oh yeah, we'll call you after treatment. Give me your phone number. Yeah, we're going to really hang out." That's almost always a bad thing in substance and alcohol. They always end up hooking up and relapsing. You know, in gambling, you don't see that as much, and because they're so coherent and they're hearing other people's timeline and they're really engaged, you know, in other people's stuff, that sometimes it's really helpful for those connections to go beyond treatment. Again, some places will do follow-up calls. There are alumni meetings through either conference calls or now Zoom reunions and ongoing support. So let's get into case management. So what is case management? You know, it's a collaborative process of assess. You know, I usually don't read that direct off the slide, but case management is a collaborative process of assessment, planning, facilitation, care, coordination, evaluation, and advocacy for options and services to meet an individual's and family's comprehensive mental health needs through communication and available resources to promote patient safety, quality of care, and cost-effective outcomes. And that comes from the CMSA website. You know, what generally does a case manager need? You know, they need a pretty extensive education and experience, and a lot of time of knowing what all the resources are. There are some great conferences on case management. They should have at least a year of working with clients, because, you know, the therapeutic relationship between the case manager is working for the client. You know, they have to have good verbal and written communication skills, because sometimes they're going to be helping their client be able to use that. certainly multitask, work under pressure, work under a crisis setting, and certainly the confidentiality. They got to be clean, you know, and be flexible, because they're also, even though they're case manager, they're working under the clinical director and the program director. You know, their duties are generally, perform tasks necessary, scheduling and conducting interviews, client referrals, client intakes. They're making sure they're accurately and timely documenting everything. They're making sure the schedule, you know, if applicable, you know, they're making sure they show up for their UA. In cases, it's like I say, rare in gambling. You know, they might assist their, excuse me, their immediate supervisor, you know, in special projects. They're sort of maybe triaging everything else with all the other therapists and counselors. They're helping find resources. They're really good at knowing how to navigate things like Indeed, housing websites and whatnot, coordinating client care with outside entities, coordinating community service where there might be community, you know, where they have to do community service for legal issues, and maybe even helping them get back to school or find a religious or spiritual organization that might be helpful for them. So I gave you all should have a copy of this. You know, this is what I use as my, you know, this will really explain case management. I use something called a continuing care plan. And, you know, I don't know if it was sent as a PDF. I'm pretty sure it was sent as a PDF. You know, if you really want to mess with it, I don't really care what you do with it. But, you know, this is what I'm, you know, I start this almost usually after the first week with a client when I'm working from a case management standpoint. Make sure that I know who their therapist is. And the first thing I do right off, and I'll usually do this within the first week, is to find out what do they need, you know? And again, you all have this. I think it's pretty simple. You could add to this. If you have things that you think might add to it, my email is marc@kindbridge.com. I'm always looking at trying to find additional things that I haven't thought about, or other people that I've worked with haven't thought about it. Is, do they have a job to return to? Financial insecurity, do they need help? Do they have legal issues? Do they need to get a new job, you know, or find some kind of educational or vocational training? What's their connection to a higher power or religion? Are there physical needs? You know, have they seen a doctor? Do they have a primary doctor? Are they seeing a therapist? You know, a lot of times when they're coming into inpatient, you know, they're sent by a therapist that they already have. Are they seeing one of the state-funded and usually mostly now they're state-funded gambling-specific treatment providers? Is their family in treatment? Are they going to GA or other 12-step? What are those programs? Have they banned themselves from casinos? Do they have internet banning from casinos? You know, are there any other needs not mentioned? You know, how could I help you? You know, you're working for them. You know, early on, one of my mentors in school said to me, you know, asked me what the difference between a sponsor and a counselor. And I didn't know. And he said, a sponsor tells and a counselor asks, right? And that's the job, like now, is for especially the case manager to ask, find out what's needed, and then find out, are there any barriers to treatment? What are the barriers to treatment? And then I really like this part. You know, I want to find out what they want, right? And so, you know, I'll just read this little quick paragraph that says, you know, in each of the following areas, identify short and long-term goals that will serve to resolve problems you've experienced in the past, aid in your recovery, and otherwise help you to achieve a greater sense of balance. Remember to make your short and long-term goals specific, realistic, and attainable. So I'm going to go through a whole, Corey, do they already have this?
Is this still part of the continuing care plan that you had?
Yeah, this is,
They should
Okay.
have access to this. And if they don't, they can put it in the chat and I can put the link back into the chat for them.
okay, cool. Thanks so much, Corey. Yeah, I really like this. And this, I'll give them their second week in inpatient. And it could be done even in an outpatient setting if you're working with them individually. Is, I want them to do a little of the work so I could help then help them realize these goals. So, just as an example, there's going to be a whole bunch of these right now. There's about 5 or 6, maybe 8 pages or 9 pages of this coming up. So just to give you an example is, physical short-term goal. I'm going to, start going to the gym 3 times a week and improve my diet. It might be something as basic as that, whereas in the long-term goals is to figure out a plan of planned hikes or how often that they want to do it, what kind of shape, maybe what kind of goals they want to put long-term of maintaining weight or endurance or other things of what they could do. Short-term goals might be just the goals that they could do while they're in treatment, which might be, the treatment facility is taking them to the gym, is that this is what I'm going to do here in the gym. Or I'm going to get up in the morning and I'm going to take a walk or do something else short term. Again, I'm going to show you a bunch of them, and I try and get the clients to really be, where it says detailed, there's a lot of the stuff here. I try them to, at least pick 3 or 4 of these recovery goals and really do a good job on it. And it'll help them eventually on the ones that they sort of not do as good a job. Again, what are their emotional goals, short-term and long-term? I want to start short-term. I want to address my trauma, my depression, my bipolar. I want to get my meds in shape. Long-term goals, might be, is to have my medication stabilized or maybe be able to go off my medication. And what I need to feel good about myself, financial, usually they do a lot of work on this, and we'll talk, I'm going to give you a little teaser in about 10 minutes on the financial part, and then we'll talk more about the financial recovery goals. But generally here, it takes up a lot of room. Generally, there are probably more financial, because that's the most concrete one that they could start on right away. Legal issues, short, long term. And a lot of these, like, again, what maybe I said before, 25 to 35% maybe have legal issues. So a lot of people just put, NA on this page, not applicable. Stress management, what are they going to do to maintain, it sort of almost goes with emotional goals. What they plan on doing, I'm going to meditate, I'm going to take a walk, I'm going to not be, I'm going to address my workaholism issues or whatever that is, get my money back into shape. And a lot of it all will tie in with stress management. Employment, a lot of times we'll see for many different reasons, a shift. They're usually their short-term goals is to maintain whatever job they have there, but realize that job might have been a trigger for their gambling, especially, I would say like car salesmen are like, if they're working in car sales, they're all talking about gambling, I've never met a car salesman and say like everybody at work is just talking about betting, it's so hard. And then maybe to find a long-term goal of changing careers. Spiritual, where they're at, it's a tough thing, and I'll talk about this at the end of the month. I'll put a lot of emphasis on spiritual. I am doing the workshop on the steps at the end of the month, and we'll talk a lot about the spiritual. And that's one of my favorite trainings about where they're at spiritually. You have a lot of people that have had, that I've worked with in treatment in all addictions that generally have a very negative influence, either a very negative childhood experiences with religion, or that or strong ones, and they feel like they've sinned so much that they're unworthy, and there's a lot of shame or guilt. And so we try and find those short and long-term goals there. And again, I'm like, here, this section here is, I'm giving them 3 weeks, if they're in treatment, for, this, I'm not asking them to do it overnight. I'm asking them to work on this and to do a really good job. And when I see them as a case manager each week, to go over what they did, and try and help collaborate if they have problems. This is their stuff. This is what they want, not what I want for them, or what the case manager wants for them. Their family recovery goals. And again, we could see, you can imagine of just sometimes it's reconnecting with their family, or because, there are many times of the short term might be divorce, which is quite often happens. The long-term goal would be to still have a relationship with them because you still have kids with them. It's not, is to be able to have some kind of long-term resolution, even though you're separated and you're not going to see each other again, but you might have kids and children in common. And it's, again, don't need to go through that. Again, educational, vocational, intellectual, going back to school, what do they want to do now? Do they want to switch, what can they learn, to improve their work, the jobs that are more available to them. Very important here. I am, like I said, I want them to focus on a few. I usually put an asterisk next to this one, is to get them back acclimated both socially and recreationally. For me, big understanding is they, because, I believe in the dopamine hypothesis and everything, that they stop doing all this stuff. And that in order for them to sort of reset their hedonic set point, that doing things that they used to like to do really helps. And for them to have a healthy, balanced life. Service, that might be 12-step service. What could they do now? In the morning, they could, like in treatment, they'll do the dishes, long term, they'll take a commitment at a 12-step meeting. Other is other, whatever you could think of. And then, somewhere around maybe 2 weeks before they're going to discharge, I start them on a relapse prevention for them to work on their triggers. And then again, this is so I can go over the plan with them and then make plans based on what we saw in the initial intake on how I could help them with it, So I'll generally have them identify 5 triggers and then what's their plan. And then I'll go over the plan with them because I think it's really important, for something to make sense. It's always client, this thing is extremely client directed. I might use some motivational interviewing. I might use some CBT to just redirect them, but it's their stuff that I know is going to work for them. This is stuff that they've come up with. So there is 5 of these things: trigger 1, trigger 2, trigger 3, trigger 4, trigger 5. And then I have a relapse plan. There is relapse with gambling, and there's a lot of relapse with gambling. But I want them to understand, here's another thing, based on my own experience, I've been very lucky. I had my own relapses, but I didn't stop going to meetings because I understood what it, I had I had seen a therapist before that. I understood the importance of still staying connected, even though I relapsed, and that there was not going to be shame and guilt in my relapse. I'm going to tell you this right now. I've been to 100,000 GA meetings, maybe not 100,000, maybe 5,000 GA meetings in my life. And I've seen the worst people, multiple relapsers, and nobody was ever chided for relapsing in all my experiences, including my own personal experiences. So I think it's important to talk about relapse and what they're going to do, of how they, of what their plan is. Are they going to go to a meeting? Are they going to contact their therapist? What they need to do in order for relapse. And I really want to make sure they do a pretty good job on figuring out what that is, and in all aspects is sort of to decrease the shame of relapse so they can get back. You know, again, here's based on 40 years of longitudinal observance is, you know, I've seen a lot of people now that I met, you know, that had, you know, when I came in 40 years ago, who now have 8 years of recovery, and it is so solid, you know, and they might have had a 3-year stint and a 2-year stint and whatever in that 40 years, but they maintain sort of a connection one way or another. And we're able to finally put it together. And I don't believe anything is ever lost in treatment. You know, again, even from now working in inpatient over 7 years ago, a lot of the patients that might not have made it right away end up making it. And I think it's really important in this thing to help set them up for that. And then, you know, sort of this is their prescription, you know, that I sort of work on with them. And again, modify this if you want, you know, email me at marc@kindbridge.com, and I'll see if I can send you an edible form, etable, not edible form. And, you know, again, I'm always updating this thing. So if you have anything that you think I've left out, especially now, there's so many new things that are coming up, but I have them, you know, I work with them because, okay, so here I'm in inpatient treatment. They've been going to meetings. So they already have been going to meetings. You know, do they have to go to meetings when they leave? Absolutely not. But you know what, they're on a roll. And so I'll help them as a case manager. I'll show them how to go onto the Gamblers Anonymous website and find a meeting schedule. I'll print it out for them and ask them what they want to do, you know, and they don't have to go to meetings every day, obviously. I let them know that there's a GA phone meeting. On this, I should have added gamblersinrecovery.com, and these conference meetings now are daily. That they should find, you know, that if they are going to do GA, they should find a home group right away. I actually put in there, I could also attend GA type meetings at gamblersinrecovery.com. To get the name, you know, I'm a big fan of the phone list in GA. You know, if anybody wants to learn about GA, I did something for University of North Carolina. If you YouTube Marc Lefkowitz and Gamblers Anonymous, I think there's a webinar I did on understanding Gamblers Anonymous. I've obtained you know, here are the people I'm going to contact, and I try and be specific. And gamblers like specific things. They like numbers. I've obtained a temporary sponsor while in treatment, and this is who that person is. Here's their phone number. I want to make sure, because I want to make sure they're doing the work, you know, that they're doing the work at least while they're there, you know, because gamblers tend to be lazy, you know, even in recovery. You know, and I want to, you know, if I could at least know that I've done my due diligence and I've had them fill this out before they left. It's a piece of paper, you know, and I have a copy of this, and I can tell you, sometimes I'll get a call 6 months down the line from a client that's relapsed, and they'll ask me to send it, because I'll put this copy in their file. They'll ask me to send a copy, you know, I'll send them a copy of this part of the continuing care treatment plan, of getting a sponsor, to work the steps and maintain a solid program of recovery. I'm a step guy. Again, I'm putting emphasis on this because they've been in inpatient treatment. Most inpatient treatment programs are going to have a 12-step component. So if I can get them to do it, that's fine. If they don't want to do it, that's fine. Planning on other support groups like AA, NA, Al-Anon, Sex and Love Addicts, Celebrate Recovery, CODA, Debtors Anonymous, you know, and I'll help them. Again, this is my job as a case manager. You know, if they have an interest in it, I'll go get on a computer and I'll get, you know, I'll sit next to them and let's figure out, you know, I'm going to teach them how to find out where the meetings are and do it with them. Are they going to attend a patient alumni meeting? Who their current therapist is, when my appointment is, and I'll try an inpatient treatment almost always to make sure they have an appointment before they leave treatment. Same thing for either a therapist, a gambling specific therapist, a recovery coach. And I'm very specific to make sure that they get that done, that first one done. So I know I've done my job as a case manager, at least to get that set up. Trauma, some people have, like I've done a lot of work with somatic experience, I find those kind of practitioners very happy. A psychiatrist, meds, family therapist. Again, I'm pretty specific. A lot of this stuff doesn't, is NA, I'm not applicable, but the ones that are, I want to make sure that I have it down in writing and that I have a date. A self-exclusion. Again, I'm sure you've had classes on self-exclusion, is what their plan is for self-exclusion, what their plan is for internet gambling blocking software, if they're going to do that. Do they have a plan for financial recovery, right? Are they going to do, and I'll talk about this in the next thing, GA pressure relief, credit counseling, TrueLink. I'm a big fan of TrueLink. I'm probably a bunch of you probably met me there at my TrueLink booth. I think I've had a TrueLink booth in Ohio. Really, probably one of the best tools. I think, you know what? I'm going to show you a quick video. We're pretty much right on time here, so I might go 1 minute over, but I think I'm pretty much right there. So TrueLink debit card it's probably one of the greatest tools for family members in helping the gambler manage their finances. It's a prepaid Visa debit card, so they don't have cash. The administrators coordinate the funding. Recovery centers use it, for, give our clients, because sometimes our clients get spending money. If we give them cash, who knows what they're going to do it. If we give them a debit card, which then they could use when they leave, we know everything they're spending their money on. They're spending parameters like the guardian, professional, or a family member. Generally, or guardian, a fiduciary could set the parameters to block trouble spots and to set alerts to be informed. I think I have a video that they made for me. Let me show you this quick video.
Today, I'm going to walk you through how to use the TrueLink card.
I don't work
Once
for them
you order
anymore.
a card,
So
log into your dashboard, and the first thing you'll see is a list of all the cards for whom you serve as the administrator. You'll notice that some names are repeated, and that is because in some cases, it makes sense for a person to have more than one card. For example, if someone wants to isolate certain types of expenses onto one card and other types of expenses onto another card. So you see a list of names here, then move across to this column because each individual card has its own dashboard. Click Dashboard over here, and this is where you actually do things like fund the card, set the security monitor, set your alert monitor. We'll go through each of these individually. Let's start with the Transactions tab. Here is a list of all transactions that have occurred. So pretty cut and dry. I'll show you a list of everything and everywhere the card has been used. This can be helpful if you want to monitor spending or if you have court reporting requirements for a cardholder that requires spending information. Now let's look at how you would fund a card. The Funding tab is up here. The card offers several funding options. You can schedule recurring payment transfers to automatically transfer money directly onto the card. You can schedule it on a certain day of the week, a certain time of the month, twice a month, or whenever the card balance drops below a certain level. For those of you with several cards to fund, you can choose to do it all at once or individually. Also, if you scroll down, you'll see all upcoming one-time transfers. All recent transfers will be listed here below. In most cases, the administrator funds the card. However, in some cases, especially when the card is used by recovery centers, someone other than the administrator funds the cards, usually a family member or guardian. We'll call this option family funding. To use this feature, you as the administrator would go to the Accounts tab here and simply enter the first and last name of the family member or loved one and their email address. TrueLink will automatically email them a link and instructions to create their own login so that they can fund the cards directly. When it is time to move to the next level of care, administrative control can be switched from you to this funder so that the protections the card offers can continue and so they can manage the settings. There is one other way to fund the card, which is by direct deposit. This allows you to provide direct deposit details from here so that money from, say, a job or another source can automatically fund the card. Next, let me show you our spending monitor. This is where you set the security features or spending parameters for the TrueLink card. There are lots of options. You can do things like limit access to cash. You can block online and phone purchases, which is a particularly helpful setting for older adults who are targets of telemarketing scams. You can make important exceptions to online and telephone block by allowing for payment of utility bills, medical bills, restaurant deliveries, phone, TV, etc. You can also block certain types of merchants. You can even block specific stores, or you can actually set limits at stores by selecting Edit here. You can block all, allow all, or set a purchase limit here. You can also block certain categories like gambling casinos, bars, and liquor stores. These settings are extremely customizable. For example, you can allow payments from the card at the gas pump right here, but then block use of the card inside the gas station. This is a useful setting for caregivers who use the card to make purchases on someone's behalf, are allowed to charge for gas, but not purchases inside the associated store. It is also helpful for those in recovery who need to purchase gas without the temptation of items in a gas station convenience store. You can also set curfews so the card is disabled during a certain period of time, for example, 10 p.m. to 5 a.m. You can help those who are struggling to make their funds last through the month. You can help them by setting a daily, weekly, or monthly budget here. You can also set a purchase spending limit here as well. This is also a helpful setting for when the card is being used by a caregiver. You can see that these settings are extremely customizable, so whether you are protecting an older adult from scams, someone's government benefits, or someone in recovery, you can configure the card to make sure the funds are responsibly available for necessary spending. Now, let's have a look at how you can provide additional oversight using our alerts function. On the Alerts tab, you can set alerts for various things. For example, when someone attempts to pull out cash, or if they're trying to use the card somewhere that's blocked. You can select how you wish to receive these alerts as either a text message, an email, or both. You can also have alerts sent to family members by just putting their phone number here and email address down here. Depending on your goals, alerts can be a great feature for the administrator and for family members. The next tab is our Reports tab. From here, you can select various reports. Here you can generate and print out a blocked charges report. This report shows any time a charge was blocked because of the settings you put in place. You have access to the monthly statement here, and you could also create customized reports. If you have a specific date range, you can just enter it here and print out that report. Of course, you have the transactions report, which is a report of the transactions that we saw earlier. You can also temporarily disable a card from the Accounts tab. So if someone loses a card, you can just temporarily disable it to see if it turns up. If not, you can cancel it and reorder a new card. But if the card does turn up, you can simply reactivate it.
So I'm gonna, that's pretty much covered everything, and I want to make sure I get you out around time. I'm not going to go over we're going to go over the financial recovery. Normally I would put this in helping you understand case management with financial recovery. We're going to do this in an hour from now. So I'm not going to go through these slides. We'll see all these slides in the next one. Here are my references of where I got most of the stuff from. They were all on the page that they actually were on, having the references. So that's pretty much, is that it for me? Yeah, that's it for me on this workshop. Wow, I missed it by a minute. And I wanted to show that video. I used to work as a consultant for TrueLink. I do not, but it's just anymore, but it's such an incredible tool. And a lot of you probably met the people, right? If you were at any of the conferences over the last 2 or 3 years, or at the Cleveland NCPG conference, that's where they sort of had their coming out. They were also at That's the one in Denver. Really an incredible tool on the program. So that's it for me on this class. What I'll do now, if it's okay with Corey, for a few minutes, I'll take, is it okay, Corey, if I take some questions now?
Yeah, we'll just, whenever we're doing questions, we can just take an hour from then. It's fine. No worries.
Yeah, so if anybody wants to ask me anything, this would be a good time to do it. If you want to take your break, go take your break. So I'm finally looking at the chat right now after, everything. So anybody got anything they need to want to ask me?
And you can feel free to unmute yourself and just ask verbally, as opposed to in the chat.
I was wondering, for full disclosure, I'm also a 12-stepper, not the GA program, but have a lot of understanding of the spiritual and higher power stuff, but also have worked with quite a few people that don't want anything to do with that, and have found some ways to work with them without any belief in God or any religious overtones. And I was wondering if you had any experience with that or any ideas on that.
Yeah, you know what? I have, in my file folder, I have the 12 steps for agnostics. And I will give them the 12 step for agnostics and just ask them, just take a look at this. See, does this work for you? It talks more about the universe as opposed to higher powers or anything else. And so that's generally the way I'll deal with it. And again, sometimes, there are a lot of the treatment facilities are 12, have a 12-step component, so it's hard to get out of it. So I'll always make sure I use that 12 steps for agnostics. You could just Google 12 steps for agnostics. It'll come up right away.
Mark, this is Ken Bazzelli, and I was interested in, as far as a longtime family therapist, we used to do a fair amount of sculpting. So I'm curious on how you've seen it with families that are dealing with some gambling. What our situation here is, I haven't had great luck in getting the whole family in, sometimes the couple. So it would be kind of interesting to figure out other hooks to get everybody in.
Okay. So no, that's a great question. So here's the situation I did, and maybe it could be recreated. If let's say you're doing family group, right? So you have whatever families want to show up, whoever the family members that show up. And then and this Dale Ryder was the most brilliant person I've ever, being able to set up sculpts. She would ask the other families to play the parts of the other family members. So there was always enough people. And generally it was, for the early onset male gamblers, it was always this tremendous disconnect with the dad,
Yeah.
And the dad, it's like, the dad was always like a bigger in life guy. The kid wanted to impress the dad. And, the dad finally said, I just, finally told the kid what the expectations are, or we'll find, late onset women with their children on of what's happening with their, but there's so many different ways of doing it. But the best way always to do it was have other people, we were able to include almost every part because we had like 5 or 6 families there. So there was always, and I started playing the grandfather and I really hated it.
Okay, I could do that. All right.
Yeah, I started playing, I knew I was getting old when they'd have me play the grandfather.
Well, thanks.
You're welcome.
Some interesting tips or ways to adapt for that.
Well, hearing no more questions and seeing none come in the chat, let's go ahead and take our hour lunch break.
Hold on, I just see one thing here. I have from Megan. I have clients who would have never gone to a GA meeting pre-COVID that go online meetings. Yeah, do they like, Megan, what's your experience with those people who are starting off from scratch, from going to online meetings instead of going if you don't mind sharing, if you're still there.
Megan popped off. She had a 1 o'clock or a 12 o'clock. So she'll be back at 1. We can kind of start back with her if we want. So,
Okay, cool. So I'm guessing no more questions.
If I can make a comment about that,
Sure.
it has been very difficult to get online meetings. GA, the central office, and the local hotline has been uncooperative. I've called both, and GA is their website and their central office. They don't want to do online meetings. So it's been very difficult to get people off the bat involved.
Bill, that's changed, and now GA on
No,
their.
it hasn't.
What?
I called them last week and they still didn't want to give me any information.
If you go to
I
Gamblers
called
Anonymous, if you go to Bill, if you go to their website, gamblersanonymous.org, there are certain areas now that are migrating where the official GA website will list the Zoom meetings, but you could just go to gamblersinrecovery.com and attend as many meetings. You know, there's so much incredible access on gamblersinrecovery.com. Have you tried that?
I have referred people to that, but
Yeah. Okay.
I'm just frustrated with the whole situation. I mean, they finally, after a year, have started to do that. They didn't for up until recently.
If you ever want to, just contact me and I'll talk to you offline about it all you want. And just email me at mark@kindbridge.com and send me your contact and I'll give you a call.
Mark, I have one more. I haven't been on that website, and you could talk maybe in the next time. I don't want to be that guy that's holding up lunch, but I've referred a number of patients to Gamblers, Friends, and Family. I don't know if you're familiar with that, but it does have readings. And I referred someone from the hotline to that. And in my follow-up call the next day, she said she went to it Saturday morning and went to a meeting live in Los Angeles, and she was calling from Ohio. So there was a pretty quick connection she was able to make on that website.
Yeah, no, I'm pretty sure we're talking about the same thing.
Okay, probably.
But the website is for the Gamblers, Friends, and Family. The website is gamblersinrecovery.com. I go every Sunday morning. Even though I'm in Arizona, I'm in Santa Monica Beach meeting, every Sunday morning. So,
well, she thought it was great going to LA. So that was great.
Okay, I guess let's take a break. I'll see you guys in about 55 minutes or 50 minutes.
Yeah,
let's
go ahead and take a break till 1:05. I think we'll extend the break just for the question and answer little session here. So we'll come back at 1:05.
Okie dokie.
All right, see everyone then.
Bye.